have our super crews. So the super crew we've got available in either the XL, the XLT, the Lariat, the King Red, the Platinum, or the Limited. So either in a 5.5 or in a 6 foot, 6.5 foot box.
And I will be covering two topics, the thyroid and diabetes. And those are called the bread and butter of endocrinology. Those are the most common cases you will encounter in clinical practice, usually related to diabetes and thyroid disorders. We will have 5 lectures, 2 of them for thyroid and 3 for diabetes. We're going to start our first lecture with thyroid function test. If you have any question or anything, you can raise your hand or send me a chat message. So what is the thyroid gland? Thyroid gland is a butterfly-shaped endocrine gland that normally sits in the front of the neck. So when we say in the front of the neck, we say the front, the center, and the lower part of the neck. Not here, not there. It's right in the middle and the way down close to the clavicles. So that's where the thyroid sits. And this is important because in clinical practice, you will find patients coming to you or people thinking they have a thyroid enlargement or a gland, and they point to different places. Very important, lower half of the neck, in the center and the front. And it produces and stores and secretes a lot of important hormones. Basically, they're the thyroxine and iodothyronine, and also secretes the calcitonin. We're not going to cover the calcitonin. It's part of the C cells, and the T4 and T3 are part of the follicular cells. And this is guided through a negative feedback process involving the hypothalamus and the pituitary gland. And why this is important, this negative feedback mechanism, we are going to cover it later again, but it's very important because this will tell you if the problem is in the thyroid, we call it primary thyroid disorder. If the problem is in the pituitary, we call it secondary thyroid disorder. And if the problem is in the hypothalamus, we call it tertiary thyroid disorder. And this classification applies to almost all endocrine glands. The adrenal glands also could have a primary, a secondary, and a tertiary disorder. And the thyroid hormones can help the body in different ways. Use the energy, regulate the metabolism, maintain the temperature of the body, keep the brain, the heart muscles functioning, and a lot of metabolic exercises that the body needs during the day. The thyroid has to be there. Almost every single cell in the body has a receptor, nuclear receptor for the thyroid hormone. And how the thyroid does this, as we said, through the hypothalamus, pituitary, and thyroid axis. And this, as you can see here, and we can, I don't know if you can see my mouse, but it starts from, usually we look at the thyroid itself. So the thyroid is under the TSH stimulation hormone, and the TSH is also under the TRH, the thyrotropin releasing hormone from the hypothalamus. And the thyroid would release the T4 and T3, and the T3 is the most active form of the thyroid hormones, but the T4 is actually the one that's abundant in the blood and is bounded most of the time. And from there, it goes to the liver and the brain and lose one of the iodine and become T3 and in the tissues that's going to function. So you don't see T3 a lot in the blood. We see a lot of T4 bound into proteins, but we don't see a lot of T3. And that has an important implication when we do thyroid function test. So how this works? the amount of TSH that the pituitary sends is the most important thing. So the pituitary has to be there for the thyroid to function. If we don't have pituitary, the thyroid will have very difficult, hard time to work. So it's always needed the TSH. When the thyroid receives the stimulation from the TSH, it turns on and release the T4. And this happens every day. And the T4 has a negative feedback. It turns off the pituitary if it is happy with the production. If the thyroid is releasing enough T4 and the tissues are happy, then there will be a turn off on the pituitary, slowing down the TSH release. And in your left-hand side, you see that it's a normal condition. The TSH value will be normal and the T4 will be normal. And this, most of the people will fall in that category. But if you look at the thyroid, and the most important thing here, the production of the thyroid, if you have too much T4 for any reason, the thyroid is producing it, the patient is taking it from outside, that will have a negative feedback mechanism on the pituitary, and the TSH will be low. And that will be hyperthyroidism. And the hypothyroidism is the opposite, when the thyroid cannot make enough thyroid hormone, and that will positively stimulate the pituitary, and the TSH will be high. And that will be primary hypothyroidism. So what is T4 and T3, and why we call them T4 and T3 as such? As you can see in this diagram here, it shows you that the thyroxine compared to triiodothyronine is almost the same, but the T3 is losing one iodine. So losing one iodine from T4 becoming T3. And you can remember from the physiology of the thyroid that we need organification of the tyrosine with iodine, and that will make it the tyrosine. And then we need we made it T1, T2, and then when the mechanism of coupling, T2 plus T2 will make T4, and that's the most abundant thyroid hormone. And when it loses iodine, when its iodine becomes T3, and it always loses it in one point. Not if it loses the iodine in becoming 3, let's say 3, 5, 3, if you can see that, that's a T3. But if you lose the iodine in the other ring, then it will become 3, 5, 3. That's a reverse T3, and that's inactive form of T3. And usually we see that in sick euthyroid, like patients in the ICU, critical care. Sometimes they will not produce the active form of T3, they'll produce the reverse T3. Thyroid function test. What do we mean by that? We mean we need to get the TSH, the T4, the T3, and the free T3 and free T4. Sometimes sometimes we need those as well. And when we say thyroid function test, we mean blood test. Most of the time it's a blood test. And this sometimes also we need the autoantibodies, even though they are not part of the function, but they can tell us about the mechanism of destruction of the thyroid. We call it thyroid autoantibodies, and they're usually antibodies either to suppress the thyroid or to stimulate the thyroid. So antithyroglobulin antibodies, antithyroid peroxidase antibody, and thyroid stimulating immunoglobulins. Those are the most common antibodies, and we can talk about them later in the lecture. And the last thing in the thyroid function test that we can do in the blood is the thyroid protein called thyroglobulin, and usually this protein is needed in monitoring thyroid cancer. We don't order thyroglobulin on a daily basis. We don't need it for hyperthyroidism diagnosis or hypothyroidism or anything. We need it only to monitor thyroid cancer. So what are the indications for thyroid function test? When do we need to order these tests? As we said, We need those when we are questioning hyperthyroidism or hypothyroidism, or to monitor the effectiveness of thyroid suppression in thyroid cancer management. As we just said, we need to order the thyroid function test, and also in hormone replacement therapy, hypothyroidism treatment, for example. Also, sometimes we order the thyroid function test in cases of a structural problem, like the patient had a thyroid nodule. Still, we need to get a TSH to find out, or T4 to find out about if this nodule is functioning or not functioning. Other thyroid function or structural test, we can do also some, this is rarely done, evaluation of the hypothalamo-pituitary thyroid axis, like we do TRH stimulation test or TSH stimulation test when we are not sure if this is a primary thyroid disorder or secondary thyroid disorder. And in practice, I haven't done this, and it's rarely done. Most of the time, you would find your answer from the conventional thyroid function test. You don't need to go for this sophisticated kind of study. The other common study that can tell us about the thyroid function, but it's not a blood test, it's an imaging technique. It's called the thyroid uptake and scan, and is used for assessment of the iodine metabolism. What do we mean by that? We give the patient radioactive iodine, they swallow it, and they come back in 4 hours and in 24 hours, and we look at the uptake of the thyroid, and this can tell us if this uptake is high, this hyperthyroidism, uptake is low, this is, and their functioning thyroid is not like taking much, could be thyroiditis, could be anything, and we can discuss this later also in the lecture. But in general, this is a very important thyroid function test that's not done in using the blood sample. Also, for the structure of the thyroid, sometimes we need to do thyroid ultrasound, and it is the preferred imaging modality to check for structure of the thyroid if you are questioning thyroid nodules or goiter or any enlargement of the thyroid. And we can do invasive thyroid study through the thyroid biopsy, that's fine needle aspiration. It's minimally invasive, I should say, because we use a very small needle directed to the thyroid nodule to tell us about the cytology of this nodule, whether it is benign or malignant. So which one should we depends on, the TSH or free T4? If you see here, there is a logarithmic relationship between TSH and free T4. The TSH can detect minor change in the T4 level in the blood. Any minor change that can, even the patient might not have the symptoms of hypothyroidism or hyperthyroidism. And way before that, there is a change in the thyroid levels, the TSH will move. Will be very, very unusual to find somebody with a TSH that's abnormal and the T4 will be normal for a long time. If you follow the T4, then it will be abnormal with time. But initially, the TSH is very sensitive to any minor change in free T4. And that's what we call logarithmic relationship. So let's talk about the TSH test. It's the best way to initially test thyroid function is to measure the TSH level in the blood sample. Period. TSH, if you get out of this lecture, just remember, if any patient have a thyroid problem, most of the time, the TSH is a screening test. Very sensitive, 97% sensitive for detection of thyroid disorder. If you see a patient with thyroid nodule, thyroid goiter, structural problem, you need to get TSH. A patient who has abnormality in their symptoms, they have issues, weight loss, weight gain, palpitation, tremors, TSH. Wherever you see a patient, that's the initial test. The TSH is very sensitive, very dependable. And we have the fourth generation now. We have first generation, second generation, third generation, fourth generation. That's very sensitive test, and it uses antibodies to detect it in the lab, and is very directed to the TSH and detected very well, 97% of the time, any minor change. So TSH is your friend for thyroid function test. Normal value is a wide, if you 0.3 to 5, you see this is a very small range, but actually it's a wide range. 0.3, if a patient live in 1 and become 0.3, this could be a logarithmic change for them, and they might actually have symptoms. So it's very important if we know the patient actual TSH, the TSH that they're happy with, and then we can record that and follow them with time. And then if they move here and there, even though within the reference range, they might be abnormal for them. And in most healthy individuals, a normal TSH value means that the thyroid is functioning properly. So if a patient come into my office, sit for 15 minutes telling me about all the symptoms in the world. She has weight gain, hair loss, palpitations, heat intolerance, everything. And the TSH is normal. Most of the time, this could be something else. TSH is very sensitive. If you, especially if you trust your lab, if you know that your lab very well, this could be minor, like maybe few percent. You have to think in the back of your mind, this problem could be related to a central issue. The TSH might be normal or low normal, and the problem is not in the thyroid, could be in the secondary. So in those little few cases that you have to think about is the secondary hypothyroidism, but primary hypothyroidism with a normal TSH does not exist. The change in TSH can serve as an early warning sign. Many primary care doctors order TSH as screening test for a patient with multiple symptoms, or thinking of getting pregnant, or during pregnancy and have more fatigue and weight gain, they check the TSH. Often occurring before the actual level of thyroid hormones in the body becomes too high, as we said. And a high TSH level indicate that the thyroid gland is what? Is not making enough thyroid hormone. And this is hypothyroidism. And the opposite, a low TSH usually indicate that the thyroid is producing too much thyroid hormone, and this hyperthyroidism. Occasionally, as we said, a low TSH may result from abnormality in the pituitary. Abnormality in the pituitary gland, decreasing the stimulation of the thyroid gland, and this is secondary hypothyroidism, and that's maybe 1% or 2%. And you don't see the, and usually there will be like a history about a brain surgery, a pituitary disorder, Sheehan syndrome, something affecting the pituitary that will be clear from the picture. Like you cannot, it's very difficult to find someone has a pituitary problem and just affecting the TRH cell areas in the pituitary. Usually it affects like the growth hormone, affect the prolactin, affect the, the ACTH way before it can affect the TSH. That's why it's very rare. I will give you an example or examples of when is it inappropriate to test only TSH. As we said before, TSH is the one that we test all the time, and we don't need to go for T4 or T3 or any other test. But there's places that you have to be careful. As we said, central secondary hypothyroidism. This is the most significant condition. An incorrect diagnosis of euthyroidism could be made based on the TSH alone. And the other one is non-compliance with the replacement therapy. So a patient is not taking her medication, levothyroxine, for example, and she will come just a few days before seeing you taking the levothyroxine, which is levothyroxine is T4 basically. And this is actually a very common mistake that people think the medication for hypothyroidism is actually to stimulate and to help the thyroid, but it's not. We give levothyroxine as a hormone replacement therapy. So you're missing some of your thyroid hormone, we give it to you in a levothyroxine. So if the patient just took it few days before the visit, the T4 will be showing high in the blood, but the TSH will be low or like a little changes there. So you have to look for both the TSH and T4 for patients non-compliant. Early stage of therapy, also the first 6 weeks, you did not reach equilibrium of the T4, then the TSH might not be settled in a normal range. So it could be a moving target. So always think of those lab tests as a moving target. You don't see that the result sit and stays in one place unless the T4 reach an equilibrium and the patient might have actually improved clinically, but the lab is still abnormal. So sometimes you need to get more than TSH. And another mistake people will do in acutely ill patients, patients in the ICU, critical care, they have a lot of issues and they get in dopamine, they get in heparin, they get in a lot of medications, they get in steroids, and they're not responding well to the management. Some doctors will order TSH, and that's the wrong time to order TSH because the TSH might be affected, and especially if the patient is very sick, the TSH actually can go first is normal, then can be abnormal and become lower. And this is independent of the thyroid status and should only be performed. We should delay or not do the TSH until the patient is out of the acute ill state. And we call this non-thyroidal illness. And we have another slide to talk specifically about that. The T4 test. T4 is the main form of thyroid hormone circulating in the blood. A total T4 measure that's bound and free hormone and can change with change in the proteins. So when do I order total T4 in my patients? Rarely. Why? Because it's bound to, total T4 include the bound to proteins and the free. The free is free, but the bound to proteins depends on the proteins. So the 70% bound to thyroid globulin binding thyroid binding globulin, TBG, 70%. But there are cases that will lower this protein, and then the total T4 will be low also. The pre-albumin and albumin also in malnutrition, they can be low and that lower the T4. So it's not reliable to order T4, but there's some cases of the thyroid disorder you need to order, few cases. The free T4 measures the not bound T4 and able to enter the body tissues. That's why it's very important test to order is a free T4, even though it's secreted by the thyroid gland as 0.3%. Most of the thyroid T4 will go and become bound. Only 0.3% will be free. The test measuring free T4 is a free T4 or free T4 index, and index is they just multiply that by the formula, like including T3. Accurately reflect how the thyroid gland is functioning when checked with the TSH. Like if you have two choices, first choice TSH, the second choice usually free T4. And the technique for doing T4, there's so many techniques, but the radio immunoassay for T4 is the most useful single test of the thyroid, and the normal value is usually between 4 to 12 microgram per deciliter. T3 test, those become like number 3 if you put them in order, like the important one is TSH, then T4, then T3, and T3, why? Because it's not like abundant in the blood and you cannot find it like accurate. Sometimes the lab would not give you an accurate result, especially in hypothyroidism. We rarely ask for T3 in hypothyroidism, but in hyperthyroidism, maybe it's sometimes it's the only abnormality you'll find. The T4 could be normal, but the T3 is very sensitive to hyperthyroidism, especially in toxic hot nodules. And again, we do the free T3. And the reverse T3, as we said before, is a biological inactive protein that's structurally very similar to T3, but the iodine is lost in a different ring and placed in a different location, which make it inactive. What are the confounding factors to be considered when interpreting thyroid function test? Is it an easy job like to see patients in the clinic and get the results of the thyroid function test? Most of the, I see thyroid patients a lot in my clinic, and usually it's straightforward. But the cases that give you a hard time, usually because you did not look at the reference range correctly. You have to see your patient age. What's the age of your patient? What's the sex of your patient? Like female in reproductive age, they have a different goal of the thyroid function test, different reference range. Pregnancy, also there's a lot of change in pregnancy, including estrogen and proteins, and that will affect the result. For example, the T4 will be high, total T4 will be high in pregnancy. That's why we don't order it. Levothyroxine therapy is very important because the T4 half-life is about 4 or 5 days. So if the patient took it like a few days before, it will show normal, even though they did not take the medicine for a month. Medication or supplement the patient is taking, like biotin, multivitamins, those could be lab interference. Non-thyroidal illness, as we said, in critical care patients. Those are confounding factors. So if you look at the thyroid function test like a lab, somebody throw it at you without knowing the background of this patient, whether it's pregnant or taking medications or they're in the ICU or they're going for surgery, taking heparin, for example, then you will be mistakenly putting this patient in a classification and having thyroid disorder and starting the wrong treatment for them. So always look at the background of the patient. What are these medications that very commonly give us hard time when we see these patients? Estrogen, females usually taking oral contraceptive pills or in pregnancy cause high levels of total T4. And this is because estrogen increases the level of binding proteins, all of them. In this situation, it's better to ask both for TSH and free T4, TSH and free T4 for thyroid, and which should typically be in a normal range. Another medication that's commonly give us hard time, and actually yesterday I had a patient, actually I needed to call the lab because in our hospital lately, we see TSH normal, T4 and T3 just above the normal range, and it become a pattern. So I called the lab yesterday about this issue, and I asked them what's going on, and they told me about the biotin. Biotin is over-the-counter supplement that can give lab interference with the measurement of T4 and T3 and TSH, and can cause a measurement of several thyroid hormone function tests to appear abnormal when they are in fact they're very normal in the blood. And so what we tell these patients usually, okay, if I see this happening, I call the patient and ask them, are you taking multivitamins? I don't even have to ask about biotin by itself because they may not know. Multivitamins, they say yes, I say hold the multivitamins for 2-3 days and come back and repeat the blood test. And usually that solves the problem. Those are and same thing for oral contraceptive pills. This is another crowded slide showing you the other type of medication and how they will affect the thyroid. And I don't advise any medical student or a doctor to memorize everything here. It's usually just to have it in your background. Like if I have a patient and has a very complex history, taking a lot of medications and have abnormal thyroid function test, then I will look up this list. I have this list hanging in my office. So I look at it and look at the patient's medication history and try to see any possibility that one of these medication will affect. But the most common you will see in the primary care clinic, that's multivitamins and estrogen. So what do you do when thyroid function test results don't make sense? Actually, before that, you have to adopt a systematic approach to the patient with abnormal thyroid function test to allow accurate diagnosis in a timely manner and avoid mistakenly unnecessary investigation and treatment. So you have to be very careful and recognize the potential causes of discordant or anomalous, as we just said. You have to know the background of the patient, the past medical history, past medication history, and understand also the basis of commonly used laboratory assays for measuring thyroid hormones and how the assay interference arise. And also you have to recognize like you have to build this, like you look at the lab, you scan it quickly, you can tell which normal, abnormal. If you see any set of labs, always look at the TSH first before you look at the rest. Look at the TSH. If the TSH is fine, then the problem could be in the T4 and T3, and the T4 and T3 if is fine, then you're fine. If the TSH is normal, but the T4 and T3 are abnormal, usually that when you need to think, scratch your head, could be a lab interference. There is something wrong here. Because yeah, I'm sure you heard about the term subclinical hyperthyroidism or subclinical hypothyroidism. Those are when the TSH is abnormal, but the T4 and T3 are normal, and the patient clinically usually have no symptoms. So usually the TSH is the abnormal. But whenever you see TSH is normal, but the T4 and T3 are not normal, then you have to think about lab interference, secondary thyroid disorder. Let's do this exercise together. Different patterns of thyroid function tests and their causes. Serum TSH on the left, serum free T4, serum T3, and your assessment. This very straightforward. This gives you the basic abnormalities in thyroid function test. As we said, always start with the TSH. The first one, TSH was normal, free T4 is normal, T3 is normal, then this is EU thyroid. EU means normal, good thyroid. If the TSH is high, then you expect something wrong with T4 and T3 because it cannot be high by itself. It has to be there. So yes, T4 is low and the T3 is low or normal, and this is primary hypothyroidism. TSH is high, but the T4 normal, T3 normal. As we said, this is subclinical. It did not reach to be clinical. It's not yet a problem to the patient. Might be symptomatic, might not be. So we have to be very careful for these patients to monitor them for subclinical hypothyroidism. And sometimes we might need to treat them because we know they're going to go to hypothyroidism. And we can support that by getting autoimmune antibodies. We can do other tests. We can ask about family history. So we know this subclinical hypothyroidism exists. We see a lot of patients. If the TSH in the other side was low, then we look at the serum free T4. It's high or normal, and the T3, as we said, in hyperthyroidism, most of the time is high, and this will take us to hyperthyroidism. Hyperthyroidism, low TSH, high T4, high T3, but T4 sometimes can be normal. If you have low TSH and the T4 is normal, T3 is normal, again, this is subclinical hyperthyroidism. We're going to go through these coming slides very quick and just give you differential diagnosis about what could be. I don't want you to memorize this. This is a list including almost everything, but you don't see this, most of this in clinical practice. You see usually one or two of this list that's common. As I said, always look at the TSH first and then look at the rest. So in this case, this is TSH is high and there is normal T4 and T3. As we said, this subclinical hypothyroidism or poor adherence to levothyroxine, as we said earlier. Malabsorption of levothyroxine could be. Drugs, amiodarone can give you this picture. Assay interference, as we said. Non-thyroidal illness recovery phase. In the recovery phase, the TSH will become high and the T4 and T3 become normal back. And also sometimes TSH resistance. There is resistance to the TSH become high, and this is very rare. So from common to uncommon to rare, the subclinical hypothyroidism all the way down to TSH resistance. On the other side, high TSH, but low free T4 and T3. And this is the bread and butter of your thyroid cases, Hashimoto thyroiditis, autoimmune thyroiditis. That's number one. But it could be not thyroiditis, could be what? Could be post-radio iodine therapy or thyroidectomy. You surgically remove the thyroid, give you the similar picture, or give radioactive iodine ablation to the thyroid, for example, for Graves' disease, patient become hypothyroid, give you similar picture. Another thing, hypothyroid phase of thyroiditis, a similar picture, high TSH, low free T4. Drugs, amiodarone, lithium, thyrokinases, antithyroid drugs, give you the same picture, high TSH, iodine deficiency or excess, affect also the thyroid function and lower the T4 and T3 and increase the TSH. Neck radiation, riddle thyroiditis, thyroid infiltration, tumor, amyloid, congenital hypothyroidism, all this can give you. Don't need to memorize this. This depends on your clinical practice. You're going to see some of these and you might not. If you see the TSH is low, but normal free T4 and T3, then the most common cause or etiology of this is subclinical hyperthyroidism, but there are other causes like recent treatment of hyperthyroidism. The TSH will be sleeping for a long time. So if I have a patient with Graves' disease and I started treatment, the TSH will remain suppressed almost for 6 months. So I don't need to repeat it in a month or 2 months, the TSH. I will follow the T4 and T3. This is very important to remember. Hyperthyroidism follow-up, usually by T4 and responding to treatment, is by following T4 and T3 because TSH will be sleeping for a long time before it comes back to normal. Drugs, steroids, dopamine also centrally affect through the hypothalamus and pituitary. They will lower the TSH, but you will have normal free T4 and T3. So you have always ask about medication history. Again, assay interference, change in TSH, but no change in T4 and T3. And most common one also non-thyroidal illness, very sick patient, not sick patient, very, very, very sick patient, the TSH will be low and normal T4 and T3. And actually very, very sick patient might have also low T4 and T3. In this case, low TSH and high free T4 and T3, and that's the bread and butter for this phenomena is Graves' disease, toxic multinodular goiter, toxic adenoma, thyroiditis, post-viral, postpartum, drugs, amiodarone. See, amiodarone can give you everything. If you have, amiodarone can give you all range of abnormality in the thyroid. So you have to be, because it has a lot of iodine. Amiodarone has almost 200 plus what you need in iodine. And IV contrast, by the way, IV contrast, like for CTs, also is iodine based. So that's excess iodine can give you a similar picture. Excess thyroxine ingestion, pregnancy related, congenital hyperthyroidism. Low or normal TSH, but you have low free T4 and free T3. That's non-thyroidal illness. That's the very common one. Central hypothyroidism, isolated TSH deficiency, and assay interference. And the last one, high or normal TSH, but also you have high free T4 and T3. And as I said, this is assay interference unless proven otherwise. You find normal TSH, but abnormality in free T4 and T3, always think of assay interference, call your lab. Levothyroxine replacement therapy, sometimes also because the TSH can be delayed, but the T4 and T3 can show that they're normal because if the patient starts to take them, they will show normal. If they took them right before the test, sometimes will give you high T4. Drugs, again, heparin and amiodarone, non-thyroidal illness, neonatal period, TSH secreted pituitary adenoma, resistant thyroid hormones, and disorder of thyroid hormone transport or metabolism. That will conclude the thyroid function test in the blood, and we will have a couple of slides in radioactive iodine uptake, and that's a thyroid function test done through imaging, and it quantitates the fraction of a dose of radioactive iodine, I-123, taken up by the thyroid gland within 24 hours. We do it in 4 hours and come back in 24 hours, and we look at the result. Normal usually uptake is about 5 to 30%, but sometimes we see elevated when the thyroid gland is overstimulated, and it could be decreased uptake when the thyroid gland is suppressed, as by ectopic thyroid producing tissue, T4 or T3. That's patients taking medication, let's say levothyroxine, and you do uptake, then there will be low uptake. And it's decreased also falsely by recent iodine load, as I said, IV contrast in CT scans. So the uptake could be high, low, focal uptake, or ectopic uptake. And here we can see that the first one to the left is a cold nodule in a background of normal uptake of the thyroid. So this patient most likely had shown low TSH and palpable nodule on exam of thyroid ultrasound, and then the physician ordered thyroid uptake and a scan to see if this is a cold nodule or hot nodule to decide whether to need to biopsy or not. And this is a cold nodule. And in grave disease, sometimes we need to do thyroid uptake and a scan for hyperthyroidism, usually to differentiate between grave disease, toxic multinodular goiter, hot nodules, thyroiditis. When we are not sure, we do this test. It's not routinely done for every patient. It's just few patients that we select and we send for thyroid uptake and scan. Toxic multinodular goiter, you can see hot nodules, you see cold nodules, you see normal uptake. You can see all the variety. The hot nodule in the lower bottom left, hot nodule is just like that upper one, the cold nodule, but it's in the opposite. This hot nodule means it took all the radioactive iodine, absorb it from the blood, and compete with the normal tissue. That's why the normal tissue, the background of the thyroid, is showing low uptake, but the hot nodule took all the radioactive iodine. And sometimes this autonomous nodule becoming like taking everything, will not leave even normal uptake for the rest of the thyroid, and you can see complete suppression of the remainder of the gland, as if the gland does not exist. And this autonomous nodule, and you can see in thyroiditis, almost you cannot see the thyroid. And I remember I sent a patient for thyroid uptake for thyroiditis, and in another institution, and they were not sure if the patient had thyroid gland or been removed because they could not find a zero uptake. So sometimes thyroiditis give you the low uptake because the destruction in thyroiditis in the walls, in the follicles, cannot grab all this radioactive iodine. Whatever the patient took is going to go through the blood and secrete it in the urine without going to the thyroid. And that's why when they come back in 4 hours, 24 hours, it looked as if there is no uptake at all. Differential diagnosis of hyperthyroidism depends on the uptake, high uptake, low uptake, high uptake on the left, grave disease, toxic adenoma, toxic multinodular goiter, TSH-OMA, that means a thyroid TSH tumor in the pituitary, and human coronographic mediated hyperthyroidism, and that's usually in pregnancies or high molar pregnancy. The low radioactive iodine uptake, thyroiditis, subacute, postpartum, painless radiation, all of these give you thyroiditis, will give you low uptake. And also patient taking exogenous thyroxine excessive replacement, factitious. Factitious means their patients are taking over-the-counter medication or intentionally taking thyroid medication for weight loss or for another gain or something, and that will show the patient uptake is low because they're hyperthyroidism, but the uptake is low because they're taken from outside. Stroma, ovarian, follicular thyroid cancer also are form of low uptake. Thyroid autoantibodies. This one slide show you the two common thyroid disorders, the hyperthyroidism, grave disease, and autoimmune hypothyroidism, that's Hashimoto's. Those are the two very common autoimmune mediated thyroid disorders. Grave disease, we check TSH receptor antibody, see 70 to 100%, almost sensitive and specific for grave disease. TSH receptor antibody. Sometimes we check anti-TPO, anti-thyroglobulin, and those vary, but depends on availability of the test. I usually go for TSH receptor antibody. If the lab doesn't have that, I will go second in line will be anti-TPO for grave disease. But for Hashimoto's, I always go for anti-TPO. Anti-TPO stands for thyroid peroxidase antibody. That's the enzyme that's help in organification. So if that is damaged because of the antibodies, then you cannot make thyroid hormones and you will develop hypothyroidism. Non-thyroidal illness, it's happened during acute severe illness requiring critical care, thyroid function, the low plasma. The characteristic for this, usually when you think about acute severe illness, low plasma T3, low normal T4, normal TSH, and high reverse T3. So in real practice, what happened, the patient will be, when they call you for consultation, for example, in the ICU, usually they have done a TSH and free T4 or total T4. Then the T4 will be low, but the TSH will be normal or a little bit high. Then you'll be asked, well, should you treat this patient in the ICU because his fatigue is not responding, blah, blah, blah. Then you tell them, get reverse T3. If the reverse T3 usually is very high, and that's confirm your diagnosis. This is non-thyroidal illness syndrome. And you tell them, I will see patient after discharge from the hospital in your clinic in 6 weeks. And that usually solves the problem. And this non-thyroidal illness is a biphasic pattern. Like early in the disease, you will see something, and later in the disease, you become very sick, you will see something. So early in the disease, you see normal TSH, low normal T4, low plasma T3, but late, very sick patient, you'll see 3 of them are low. TSH is low, T4 is low, T3 is also low. And some people actually think this is a supporting mechanism, like the body in the ICU does not want to work the metabolism. They're trying to preserve the energy. So the brain, the hypothalamus will slow down the TRS stimulation for the pituitary, and the TSH also will respond by going down, and the T4 and T3 will be going down because the thyroid also does not want to produce more thyroid hormones in this sick state. So some people think it's a protective mechanism by the brain. And it's similar to fasting. Fasting in healthy individuals, sometimes prolonged fasting can give you similar mechanism. The T3 slows down, and the reverse T3 will go up. And you can see here, depends on how sick is the patient, how the difference. The reverse T3 actually the first one to go up, and then with time the TSH and T4 will go down as well. I have a couple of cases. I'm not sure we're good in time, but we're gonna go quick just to reinforce what we have talked today. Case 1, 45-year-old lady presented to you to your clinic actually complain of palpitation, tremor, sweating, and loss of 5 kilograms over the past 2 months. And the exam showed tremors, stare look, lid retraction, moderate goiter, and the pulse was 96. What do you suspect?
Graves' disease.
Yes, grave disease, hyperthyroidism. I would say hyperthyroidism first. Okay, it might be Graves, might not be, but what goes for the Graves here? The stare look and lid retraction.
Yes, sir.
But those stare look and lid retraction actually they're part of the hyperthyroidism itself because of the free T4 and free T3 that are high. That give a stimulation of the muscles of the eye and that give you lid retraction. But the exophthalmos, that's the glycoprotein behind the eyeballs, those are related to the autoimmune nature of Graves' disease. But toxic multinodular goiter can give you the lid retraction actually. So until this point, we might not know for sure. So this suspect hyperthyroidism, most likely Graves' disease, but we have to think about what can we order to document. We didn't do any lab, right? So we have to start with what? TSH is the best screening test for primary hyperthyroidism, and the result came back very low. Sometimes it's undetectable. And the free T4, 39. Normal is up to 22. So this is a very hyperthyroidism. And what is the cause and how do you find out? You can check the autoimmune antibodies for the TSH, like thyroid stimulating immunoglobulin or TRAP. Can do thyroid uptake and scan. Can do thyroid ultrasound to look for this goiter on exam. That could be multinodular goiter. And even though if you did the thyroid ultrasound, still you have to do the thyroid uptake and scan. I think it's very important if you're trying to differentiate. And why? Because sometimes, even though the patient could have multinodular goiter and it's toxic, but might not be all the nodules in this goiter are hot. Maybe one of them, the largest one, actually is a cold nodule. And in that case, if you document a cold nodule in the background of toxic multinodular goiter, and it meets the ultrasound features for biopsy, then you have to biopsy. Okay, that's why thyroid uptake and scan is very important if you feel in some structure change in the neck. Case number 2, 25-year-old woman with no significant past medical history presented to your office with fatigue, weight gain, cold intolerance, and hair loss. Very common. We see this all the time. Family history of thyroid disorder as well. The exam showed overweight woman in no acute distress, and then in the neck, you felt a small non-tender goiter. You suspect hypothyroidism. What test will you order to support your diagnosis?
TSH.
Always TSH is the best screening test for primary hypothyroidism, and the result came high, 14. So what's your working diagnosis? The most common thing, Hashimoto thyroiditis. So what's your next to support your suspicion? You repeat the TSH, because especially if you're not, if you work with your lab and you're familiar, personally, I divide my time between my clinic and the lab. Because in endocrinology, if you're not friend with the lab, then you cannot practice well. You have to trust your lab. And you have to follow them, and they have to do the quality measurements all the time, and you have to be good at what you have to have the critical eye, what I mean. So we repeat the TSH, especially if they bring for you like a test from outside, a small lab or a free screening test done somewhere. I will repeat the TSH in my own lab and check also the free T4. And the result, the TSH came back also high, and the free T4 came in the low side. Do I need to do order supporting tests in this case? Do I need anti-TPO antibodies? No, I don't, because I have almost all of the information in front of me from the history from the exam and from the lab. So anti-TPO antibodies, if you are not sure, then you order it. If the patient has no family history, if they have family history, that's supported. And sometimes even if it is negative, would it change my plan? You always ask yourself, if you are in question, need to order a test or not. If ordering this test is going to change your plan, go for it. If not, don't do it. And most likely the insurance won't pay for it. Case number 3, 27-year-old lady presented to her GP for general checkup, and she's planning to get pregnant. Good for her. TSH measured prior to conception, and it shows TSH 11, high. The normal 0.27 to 4.25 in that lab. And that's another important thing. Always don't memorize the normal range. They should be available in your test. They should be available in real practice. Patients should come from a lab with a test. They should have the normal range, because there are different methods of doing endocrinology test, not only the thyroid function test, all endocrinology tests, there are different ways. So you need the reference range for that lab so you can make a judgment about the test in front of you. So what is the next? Repeat and add the 3 to 4. As we said, we always want to repeat the test, especially if it was done in a non-trustable lab or outside your hospital. You have, because you're going to commit them on a lifelong treatment. Should I commit somebody to lifelong treatment without confirming the test that they brought from outside? No, I will trust my own lab and I will repeat the test and then add 3 to 4 and repeat. TSH was again high, 11.5, and the 3 to 4 was 14 and normal, but in the lower side of normal. So what's my diagnosis? Subclinical hypothyroidism. High TSH, normal T4, and the patient is healthy and she's planning to get pregnant, and now she has subclinical hypothyroidism. Should I treat or not? Of course I will treat her. She's going to get pregnant. The baby doesn't have a thyroid for the first 3 months after conception. No thyroid, no thyroid hormone. Start to make thyroid hormone in the 7th week and is not even ready until 3 months. So the first trimester depends on the mother thyroid. And if she has issues with her producing T4 to the degree that the TSH is 11, then I need to correct her and to goal of TSH less than 3 in the first trimester. And this will conclude my presentation for thyroid function test for today. Any question?
Yes, doctor, I have a question. Why didn't we order T3 for hyperthyroidism in the cases that you just gave us?
For hyperthyroidism?
Yeah, you said T3 is helpful for hyperthyroidism, so why didn't we order it?
Because I got my answer from the 3T4. So if the 3T4 came back normal, then I will go for the 3T3.
Okay, thank you, doctor.
Okay. Usually there's some orders, they call it thyroid function panel. It will bring you the TSH, total T4, free T4, total T3, free T3, all together. And sometimes you have to break them down, order the TSH and then order T4, and depends on in real practice, depends on the insurance coverage, depends on how much this will cost the patient. There is a lot of influence in this, but in the ideal thing, you need the TSH and free T4 and free T3. I will tell you, in this case particularly, as you mentioned earlier, one of your colleagues was saying this could be grave disease. So for grave disease, usually T4. If this was, I was thinking of toxic nodule, I might order the free T3 as well, because if the free T4 will come normal and T3 will be high. And this is very common in real practice. The toxic nodule loves to make T3s more than T4s. And grave disease makes more free T4 than T3, but both will be high eventually.
Doctor,
Yes.
I have a question. So in case of secondary hypothyroidism, we'll have TSH, T3, and T4, all of them low, right?
All sometimes no. Sometimes you will find normal TSH. It doesn't have to be low, but the T4 and T3 will be in the low side. Okay.
Yeah. Okay.
It's a moving target. Like it depends on when did you find it, like early in the disease or late in the disease. Like if actually this is late, the TSH would be low, the T4 would be low, the T3 will be low. But sometimes, as we mentioned, this secondary hypothyroidism in different slides, because it in different set of labs. It can be low, could be normal TSH, and the same thing for T4, could be low, could be normal. Okay, and the patient sometimes will be symptomatic. And that's why you would think about ordering these lab tests. So if the patient has fatigue, weight gain, hair loss, dry skin, all the symptoms of hypothyroidism, and then you have this kind of lab that doesn't make sense, like it's not, usually you should see a high TSH and low T4 and low T3, and that's the primary hypothyroidism. But if you don't see that and you see something different, always in the background would be this is a secondary hypothyroidism or not, and could be a wide range.
Okay. Thank you, doctor.
You're welcome. Any other question? In the second lecture, we will talk about, more about the thyroid disorders. We'll focus on the clinical presentation of hypothyroidism, hyperthyroidism, talk about briefly thyroid nodules will be covered in another lecture by another doctor, but we can just touch it little here. Thyroid cancer follow-up also is very important. But the main thing for thyroid disorders are either functional disorders or structural disorders. Functional, either hyperthyroidism or hypothyroidism. Structural is thyroid nodules and goiter. And always TSH, free T4, free T3, and sometimes thyroid uptake and scan, sometimes thyroid ultrasound, and that will cover all the thyroid issues. And if you have any questions after you reviewing these slides, you can prepare them. And next time on Sunday, when we cover the second part of the thyroid disorders, you can ask me those questions as well. Thank you so much.
Thank you, doctor.
Thank you. Manasik?